Good day. I'm Berthold Koletzko, Professor of Pediatrics at LMU, University of Munich, and I have the great privilege to act as the coordinator of the ImpENSA Project, a South African-European collaboration aiming to improve knowledge and skills in early nutrition and health in Southern Africa. I have no conflict of interest to declare in relation to this presentation. So ImpENSA is a capacity building project funded by the European Union Erasmus Plus program that brings together 6 universities, 3 from South Africa, 3 from the European Union, along with the Association of Dietetics in South Africa, the host of this conference, and the Nutrition Society of South Africa. The project is coordinated by LMU University of Munich in Germany. It's funded by the European Union with almost 1 million euro, equivalent to 17 million South African rands or 1.2 million US dollars, and the project lasts until January 2023. What is our mission? We want to contribute to reducing the triple burden of malnutrition in Southern Africa, and thereby to improve to neurodevelopment and the ability to learn, to reducing stunting and malnutrition, and to preventing of childhood obesity, as you know, all of these being major challenges for the people in South Africa. And thereby, we plan to contribute to achieving the United Nations Sustainable Development Goal 3, that is to ensure healthy lives and promote well-being for all at all ages. So how do we plan to achieve this? The ImpENSA concept is to enhance both the knowledge and the practical skills of health workers that counsel pregnant women and families with young children. And we wish to do this by applying innovative blended learning, combining state-of-the-art distance learning, e-learning, with face-to-face courses using latest learning designs, pedagogic formats, and state-of-the-art technology. In the ImpENSA project, the partners co-create the e-learning and face-to-face training on healthy lifestyle and nutrition during the critical first 1,000 days. And we apply the latest scientific evidence in early nutrition research, educational theories, and instructional design. Thereby, we also contribute to foster South Africans' higher education institutions and professional associations' position as qualification providers for the health workers. So we develop and broadly implement an effective evidence-based course providing knowledge and counseling skills. It addresses nutrition and lifestyle in early life and focuses on micronutrient supply. It is aimed to match the specific needs of health workers in South Africa that are not covered by other current continuous professional development programs. We are not only developing and implementing the program, we also perform a very thorough evaluation of suitability, efficacy of the strengths and limitations, hoping that we can further improve the program. And we are planning to establish an infrastructure in South Africa so that the delivery of the blended learning can be effectively and efficiently applied and be made sustainable. So how is the consortium built? LMU is coordinating the program, and I'm assisted by Dr. Shweta Freha, who is my deputy coordinator. We have 2 universities in the European Union, in addition to LMU, which is the University of Southampton and the Medical University of Warsaw. And in South Africa, we have the Northwestern University, University of Cape Town, and Stellenbosch University, along with the Association of Dietetics in South Africa and the Nutrition Society of South Africa. All partners delegate 1 representative to the project steering committee, which basically is guiding the decisions in the project. We have 1 implementation officer each in Europe and in South Africa that are coordinating the work and making sure the implementation is effective. One, Rungravi and Estelle Stridham. We have a dissemination, exploitation, and sustainability board that basically promotes the rollout and the continuation of the project after project end, after funding end. We have a curriculum implementation panel with key stakeholders from outside of the project, and a group that is responsible for reporting. We are implementing the project through a structure of 6 work packages. 3 of them have already been completed. In the first one, we performed a landscape analysis of the current training opportunities in South Africa and the unmet needs. Based on this, we developed the content of the modules and established a state-of-the-art e-learning platform in which we incorporated the module content. We are now in the phase of implementation and piloting and building the monitoring and evaluation. And at the same time, we are aiming at wide dissemination exploitation of the developed program and building a sustainable approach for long-term continuation. So the program is built on 3 modules that are addressing the health workers. The first module provides information in an e-learning format on micronutrient nutrition in pregnancy and early childhood, and lactation, of course. And the second e-learning module is providing information on interactive communication that can support behavior change, counseling skills. The third module then is a face-to-face module where the information module 2 is converted into practical application, where there is practical training on interactive conversations that can actually induce changes in lifestyle in pregnant women and families. In addition, we have the 4th module to train the trainers, to train the coordinators that can then apply module 3 in practice. And with this, then, the trained coordinators can implement the program on the ground in South Africa. So learners will be encouraged to go through module 1 and 2 online, either at home or at work, or even with their mobile device, wherever they are, which is then a prerequisite to continue with module 3. So these are completed with multiple choice tests, and once these have been passed, then the learners are able to enter into module 3, applied with 2 coordinators from the Northwestern University and 2 coordinators from Stellenbosch and Cape Town universities. So it can be applied all over the country. And then with the package of the 3 modules, the whole learning goal should be completed, a certificate can be provided, and the learners can then translate this into action in their everyday work. We are developing a business plan to create a social enterprise, not for profit, to enable continuation of the program after the end of the European Union funding, so that we can broadly implement not only the e-learning, but also create a face-to-face training facility or hub. So we hope to generate financial support from donors to sustain the training course delivery. We want to embed the training course into existing programs and qualifications for health workers and also for trainees, students, for example. And obviously want to maintain the e-learning modules on the established Moodle platform and be able to revise and update the modules and re-accredit for the CPD points. Already the program has been accredited for 15 CPD points in South Africa, where health workers need 30 of these points per year, so half of their points they can already achieve with completing the ImpENSA program. And we are in very good conversation with the Department of Health at the Western Cape that is currently exploring whether ImpENSA could be incorporated into their training strategy which we hope can happen because it would be a great opportunity to roll it out in a sustainable fashion. I would like to thank a fantastic team of wonderful, bright, knowledgeable, and dedicated people who make it all happen. It's only possible with the close collaboration of these people. And it's been just a wonderful journey where we built friendship and close collaboration in spite of the challenges of the COVID pandemic, which made us meet more frequently online than face-to-face now. I thank you all for your kind attention, and if you want to find more, go to our website, early-nutrition.org ImpENSA, or look at our tweets at Early Nutrition. Thank you very much indeed for your kind attention.
Can I go ahead? Okay, thanks. Well, thank you very much to both ETSA and NSSA to give me the opportunity to present in the symposium. And I will just give a short overview of some of the nutrition challenges that we experience in South Africa, focusing on the first 1,000 days with a bigger focus on infant and young child feeding. Now, South Africa is one of the countries that carries the triple burden of malnutrition, which is defined by a high prevalence of maternal overweight and obesity, a high prevalence of maternal anemia, as well as a high prevalence of childhood stunting. In addition to these types of malnutrition, we have got various other micronutrient deficiencies that are prevalent, and we also have an increasing prevalence of overweight in children under 5. And all these types of malnutrition we can link back to the South African diet, which in general is a cereal-based diet with very little variety. Of great concern is particularly the low intake of dairy products, as well as the low intake of vegetables and fruit. The per capita intake of fruits and vegetables in South Africa is below 200 grams per day, which is less than half of the WHO recommendation of 400 grams per day, which has been associated with a lower risk of non-communicable diseases, but also in terms of a lower risk of micronutrient malnutrition. Over the past years, sugar-sweetened beverages, sugary foods, salty snacks, and highly processed foods have become an integral part of the South African diet. And when consumed in large amounts, these then contribute to the high prevalence of overweight and obesity in the country, but also it replaces some of the more nutrient-dense foods in the diet, which then contributes towards micronutrient deficiencies. These unhealthy foods are already introduced at a very young age to children. National data show that between the age for children 6 and 23 months old, many of them received these foods on the day before the interview. And we have a very low 23% of children in this age group who are receiving a minimum acceptable diet. And this indicator is based on the breastfeeding status of the children, the number of meals that the children receive, as well as the diversity of the complementary diet. So if we look at the breastfeeding status in South Africa, this is national data of 2016. Although we have a relatively high initiation rate of breastfeeding, about 85%, the exclusive breastfeeding rate is very low. And this is because of the early introduction of liquids other than breast milk, as well as complementary food. And already during the first month of life, we have only 44% of children who are exclusively breastfed. And as the children age, the exclusive breastfeeding rate drops. And at the age of 6 months, very few children meet the recommendation of 6 months exclusive breastfeeding. In terms of the continued breastfeeding up to the age of 2 years, that also is low, and it drops during the second half of life. And when we get to 24 months, very few children are still being breastfed. Smaller studies have shown that as breastfeeding is stopped, or as formula milk feeds are stopped, this is not being replaced by milk feeds or normal milk as a drink. Children do get some milk, either fresh milk or sour milk over their porridge, or some yogurt, but generally the intake of these dairy products are very low. And we've shown in studies that at the age of 12 months and 18 months respectively, a high 75% of the children have a calcium intake below the estimated average requirement. And this is a concern, as the South African study has shown, that a low intake of both calcium and vitamin A is associated with linear growth retardation and stunting. And the authors of this paper then argued that the low intake of milk contributes to the high prevalence of stunting in the country. I just need to mention here that this low intake of calcium is not unique to the specific age group, as a recent desktop study has shown that calcium intake is low through all the life stages, from childhood, adolescence, adults, as well as the elderly. If we then go to the dietary diversity of the complementary diet, this slide shows data for infants in KwaZulu-Natal between the age of 12 and 24 months, where 79% of the children consumed a complementary diet of low diversity versus only 21% with adequate diversity. The red line indicates 50% of children who consumed foods from that food group during the recall period. And if we look at the low dietary diversity group, only the starchy foods were consumed by more than 50% of the children. And this then again highlights the cereal-based diet and the very low diversity for those who have a low diverse diet, compared to the 20% of children that had a more diverse diet, and 5 out of the 7 food groups were consumed by at least 50% of the children during the recall period. Now, we know from literature that dietary diversity is a proxy indicator for the micronutrient adequacy for the diet. And at this very young age, children consume small amounts of food and therefore need nutrient-dense food to achieve their high nutrient requirements during this age. And this slide then shows the micronutrient density, that's the nutrient per 100 kilocalories for several of the key micronutrients. And the complementary diet that was of adequate diversity had a significantly higher nutrient density compared to the low diversity, again highlighting the importance of having a diverse diet and the importance of the nutrient density in this very young age. If we look at the top part of this slide on the left-hand slide, that shows the percentage of children at national level between 6 and 23 months who consume a minimal acceptable diet, and that is according to the lowest to the highest wealth quintile. And it is clear that those in the poorest quintile receive the lowest percentage of children receive a minimum adequate diet. And we can draw the exact same graph for dietary diversity, which then indicates the inequality that we see in terms of nutrition during this very young age. We also know that in South Africa, price of food is the main consideration when people buy food. And in households where resources are limited, when they do food shopping, they prioritize to buy the core foods first. And the core foods are the minimum foods that they need to at least put a meal on the table. And this will be mostly the starchy staples, such as maize meal, rice, and some sugar beans, some frozen chicken pieces, and then oil, tea, sugar, and some salt and spices. And this constitutes about 50% of the household food basket. depending how much money they've got left from the household food basket, that will depend on which foods they then buy. So any factor that will influence the amount of food available for the household food basket, such as a sharp increase in food prices, increase in increase in transport cost, will lower the amount of money that they have available for the food basket, and therefore they will purchase less of the nutrient dense foods. And if we think in terms of complementary diet, once the children go into their second year of life, they consume very much similar foods that the household eats. So if the household only buys the starchy staples, that will then directly also affect the foods that are given to children during their second year of life. If we look at factors that influence the household's ability to buy a nutritious diet, this is data on the unemployment rate in South Africa. And what we see is that between 2010 and 2019, there was not such a sharp increase in unemployment. But during the last 2 years, we've seen a very sharp increase with a current unemployment rate at close to 33%. If we look at the expanded unemployment rate, which includes those individuals that can work but no longer seek work because they are discouraged from seeking employment, we're sitting at an expanded employment rate of 43%. And this part of the pie chart in terms of those that no longer seek employment has increased a lot because of COVID. And then we also need to keep in mind that food and nutrition security is not stable, and if shocks occur, that will affect various services that can affect the nutrition of children. The slide just shows some of the health services of one of the provinces in South Africa, how COVID affected it. The blue bar is the average since 2018 to 2020, and we can see the green bar, that was the month where we had the hard lockdown. There was a drop in the coverage of measles immunization, but it seems to have recovered quite quickly after that. If we look at vitamin A supplementation at the health clinics, again, the blue bar is the average, the baseline between 2018 and 2020. The green bar, when we had the hard lockdown, a very sharp decrease in the number of vitamin A supplements that children received, and this has not recovered as quickly as the measles immunization. We also just need to keep in mind that this slide is only for one province, and it could well be that some of the other provinces show an even more unfavorable picture. Last slide that I would like to put up, and this is a framework that was published in the recent Child Gauge in South Africa, and it comes from the chapter that was authored by Nazia Sayed, which basically shows the complexity of all the factors that affect infant and young child feeding. And I think important is that there's a lot of focus on breastfeeding, but there should equally be equal focus on the complementary feeding. And it's a whole range of factors that needs to be considered and needs to be addressed to create an enabling environment for the households, especially those in the lower sector of the population, low socioeconomic sector of the population, to enable them to actually give their children a nutritionally balanced diet. Thank you very much.
I'm sharing. Okay, let me just stop sharing and I'll try again. So, kom op, sorry. Okay, thank you. Am I on? Thank you. Good morning, everyone. Yes, so my presentation will focus on the training needs and challenges of South African healthcare professionals essentially working in the first 1,000 days. And we will focus on the specific training needs and challenges of healthcare professionals with regards to providing support to women and families to improve their diets. So the magnitude and concerns of malnutrition, including overweight and obesity, stunting, wasting, micronutrient deficiencies or hidden hunger, has been highlighted and discussed in a number of presentations so far. And to successfully address malnutrition requires a systems approach, including strengthening the health system. And one such an example within the health system strengthening is to improve counseling and support provided by healthcare professionals or healthcare practitioners to end users, whether it's antenatal care, mothers with babies, or adults with non-communicable diseases. So we also know that optimal nutrition, especially during the first 1,000 days, provides a critical window of opportunity to improve growth and development. And this is where ImpENSA or the ImpENSA Project fits in. So Professor Berthold provided a very nice introduction to the ImpENSA Project earlier, and he also referred to the development of an evidence-based training program to equip healthcare professionals with knowledge and skills to better support women and families to eat well. So before we... Oh dear, I apologize for that. So go please stop. I apologize for that. Let me just hide that button. So before we can develop such a training program, we need to perform a training landscape analysis to first explore the existing training landscape, but also to explore the training needs and challenges of these healthcare professionals working in the first 1,000 days. And in the interest of time, I'm just going to focus on the second component. So what we've done is we've conducted focus group discussions with a number of healthcare professionals, including dietitians, nutritionists, nurses, midwives, pharmacists, and doctors from both private and public settings using a semi-structured interview guide. And then we've performed a thematic analysis to analyze the results. So I'm just going to briefly highlight aspects from the 4 main themes that we've identified from these focus group discussions. And the 4 themes included challenges to provide support, the healthcare professionals' training needs and preferences with regards to training content, training mode, but also training facilitation. We also identified challenges to undertake training or barriers for healthcare practitioners to do training. And then we also looked at what motivates healthcare professionals to do additional training, what will enable them to continue updating themselves. In terms of challenges to support women in families to eat well, it's important to note that there were slight differences between healthcare practitioners working in the public versus the private sector. We've also identified a number of implementation barriers. And with that, I mean things such as poverty or food insecurity. And I think Mieke provided a very nice overview just now of the challenge of poverty and also food insecurity. And even though healthcare practitioners may have the knowledge to educate women to buy food, if they don't have the money to physically buy the food, then that's an implementation barrier. In terms of limited resources, Healthcare practitioners don't always have the time or the knowledge or the skills to support women and families to eat better in their line of work. And some other factors that we identify is inconsistent messages or simply too much information. Healthcare practitioners sometimes find themselves in a scenario where they do have the time to educate, for instance, mothers to eat better, but the content or the messages available to them is inconsistent, or there's simply just too much information. They don't know what exactly to tell the mom to feed a baby. In terms of training content, the training needs and preferences with regards to training content. In general, training content should be evidence-based, it should be up-to-date, and it should have practical relevance. Specific information and skills that were identified for inclusion in the program with regards to the first 1,000 days, specifically nutritional recommendations, updated nutritional recommendations for antenatal care, breastfeeding, but also complementary feeding. And they don't just want the nutritional recommendation, but they also want practical nutrition messages, especially the nurses and the pharmacists and the doctors. That's not so glued up with regards to practical nutrition measures. They often need to provide practical advice to mothers, but they don't know the practicalities behind that. And then a big need that we've identified amongst these healthcare practitioners is a need to learn more about behavior change communication and to really have the skill to communicate with mothers in order to change their behaviors. Then a number of other things that we have identified in terms of training content. They would like to have downloadable practical handouts that they can actually hand to mothers. And these handouts should also be available in other South African languages. With regards to training needs and preferences when it comes to training mode, in terms of the mode of delivery, the majority of healthcare practitioners wanted a blended training approach where face-to-face or facilitated learning is combined with online or e-learning, which is then self-directed. In terms of the duration of additional training, they prefer shorter time slots, varying between 45 minutes to maximum half a day as opposed to long days. And these time slots should cover single topics or themes per time slot. And again, with regards to the frequency, most of them preferred shorter training sessions, more frequent, as opposed to, for instance, a 3-day workshop. Because I just want to remind the audience again that we are looking here at continued professional development training or ad hoc training that healthcare practitioners can do after hours, and that does not necessarily need to be included in a normal work day. So we actually asked these participants that took part in our study, what types of or format of training have they received additional training? And then the majority used or have received face-to-face training. 32% received blended training, which is again a combination of face-to-face and online. 48% has enrolled in online courses, and 45%, mostly those working in the public sector, has received workplace training, additional workplace training. In terms of the training needs and preferences with regards to training facilitation and instructional design, the facilitator should be an expert in a field with subject content expertise, but also with practical experience. In terms of instructional design, the content should engage the learner. It should be visual, and it should simulate practice, and it should include a lot of case studies or case scenarios, which is really, again, have practical relevance. When we look at the challenges to undergo training or the barriers that prevent healthcare practitioners to do additional training, again, this slightly different between those working in public versus the private sector. Again, limited resources was a big barrier. Limited time due to workload. A lot of the private practicing dietitians, for instance, need to use own time after hours or take annual leave not to lose salary to do additional training. And then, of course, the cost involved is also a barrier to additional training. Limited access. There were some practitioners saying, yes, that access to internet access to a computer is a barrier for additional training. And then some of the healthcare practitioners also said, specifically with regards to additional training in nutrition, it's not a main priority, or it may not be part of their direct scope. So we've also actually asked the participants that took part in our focus group discussion, do they have access to technology, and what do they have access to? You can see a very high percentage of our participants had access to a computer, a smaller amount, only 38% had access to a tablet. Again, most of them had access to a smartphone, 80%, and then 86% had access to internet. I think it's also just important to note from these statistics that these stats are not standing on 100%. So even though, we assume a lot of people these days do have access to internet and do have access to a computer, in our setting, there is still a percentage that actually do not have access to these facilities. And then when we look at motivation to do training or enablers, CPD points was a big incentive. Also, if the training is sponsored by an employer, or it's free, or it's in work time, that would be an incentive. The feeling of empowerment and capacity building, knowledge and skill gains is also an incentive to perform training. And again, the population we looked at, 30% reported, and including in the 30% was all the dietitians and nutritionists, that the additional training that they did do in the past were either CPD opportunities, with the main reason to obtain CPD points. So again, CPD points is a very, very big incentive to do additional training. Then the participants would like to receive a form of recognition, a certificate or form of accreditation. They would like to be assessed, evaluated. They don't just want to do a training course and not receive feedback in terms of how did they do. The training course must be affordable. And if they have an interest in the topic, that will motivate them to do it. If it's self-paced or in own time, that will also act as motivators to enroll in the training. So if we take these findings together and just draw rough recommendations for a training program, a blended approach where face-to-face activities is combined with e-learning activities, because the face-to-face or the interactive, especially interactive activities rather, allows for discussion and asking questions. And the healthcare professionals did say, they would like to have interaction with a facilitator, especially if it's skill-based activities, or if when they have questions, or if they need to practice something. And then obviously the online or the e-learning component would be for more theoretical concepts. And again, they would like to have it divided in shorter sections per topic. The content should be evidence-based, up-to-date, and have practical relevance. Again, it should be facilitated by an expert with practical experience. And then the content should include practical nutritional messages, visual content that's, again, based on real-life scenarios, including, for instance, case scenarios and case studies. And then a big incentive is CPD points. So the recommendation would be to get this training program accredited and allow the healthcare practitioners to actually get CPD points when they do this training. So I would just like to use this opportunity to showcase our modules a little bit. And again, Berthold did refer earlier to the two online modules, module 1 and 2. And the first module focused on optimization of micronutrient nutrition during the first 1,000 days. And it includes a focus on the importance of optimal micronutrient nutrition. And again, just linking back to Mieke's presentation, where she really highlighted the importance of, for instance, calcium and iron and vitamin A, and that we still have a lot of problems with micronutrient deficiencies, especially also in infants and young children. And then it also focused on optimization of micronutrient nutrition, not only during pregnancy, but we also included a unit on lactation and complementary feeding. Because as Mieke also mentioned, the complementary feeding period is often neglected a bit. And then the second module focused on communication to support behavior change. And this is the theory underpinning the communication to behavior change skills module, which is then the third module and I'll just talk a little bit more about the third module, but just to also showcase some of our instructional design components or the media module components in these modules. It's evidence-based, and I'd like to draw your attention to the rainbow. This is in module 2, but specifically also given the complexity of the underlying factors contributing to malnutrition, healthcare practitioners really need to also look at the wider determinants of health, the individual factors, the social and community networks, the living and working conditions to truly assist mothers to change their behavior. The content then include practical recommendations, again, with very nice visual graphics. We also base the content on national and international guidelines to ensure, again, that the messages are consistent, and we also really highlight the practical messages that's already available to healthcare practitioners and mothers. Then we've also included a lot of interactive activities. For instance, here's a timeline of the first 1,000 days, and then the participant can click on the tabs and toggle between, for instance, life course, growth and development, and requirements during the life stage phases. We also included in-lesson activities to serve as self-assessment. For instance, an example would be a question on which of the 2 meals contain iron that is more bioavailable, to really engage the learner, but also to make them think and to give them an opportunity to self-assess their knowledge. Then we've included a number of scenario-based videos where we used real actors, and we've used, everyday examples of everyday dialogues that you will typically find between a nurse, for instance, and a pregnant woman in a clinic setting, and where she will come to the nurse with the typical problems, and then we will mimic, the advice that the nurse could give to the patient. And we've also included a number of animated videos for contextualized examples. And then just quickly in terms of the virtual module, so this is module 3. It's a skills-based approach to enhance communication and support behavior change. It's live facilitated sessions using interactive functions in the Zoom platform, which also was very successful. We've completed our first virtual session just recently, and I must say the virtual online healthy conversation skills was as effective as the face-to-face. It was actually very, very useful to really enhance skills in terms of communication for behavior. So I would just also like to give a big thank you to the entire ImpENSA team that's involved in this project, but I would like to specifically express my thanks to all the individuals that were involved in the actual focus group discussion, collecting the data and analyzing the data. And just if you would like to find out more and connect with ImpENSA, again, I'm also just referring you to the ImpENSA website and the Twitter account. Thank you very much.
Thank you very much to all the presenters for a very informative session. About minutes for questions. Prof. Lena, I'm handing over to you. I think there are 3 or 4 questions in the session.
Yes. Thank you, Chantal. First of all, thank you to Berthold, Mieke, Lize, well done in telling everybody about this great project that we are busy with. So it's also a privilege for me to be part of the ImpENSA family. I have one question for you, Mieke, if I can maybe start with you. There was a question about the data that you presented, and the question was whether you think that lactose intolerance could be a barrier for this potentially not receiving sufficient milk and dairy consumption. So is lactose intolerance basically a problem in the population that you studied?
We don't look specifically at lactose intolerance, but I do believe that it can play a role. But if we look at the very high percentage of children who don't consume adequate amount of milk, it is impossible that they are all lactose intolerant. And according to the literature, the main reason for this very low intake of dairy is firstly the cost of the products, but also the cost of refrigeration. As many people do not have fridges, although it's also money for the electricity, for the refrigeration. So I think it's more the cost for both the product itself as well as the cost of the refrigeration, which is the major barrier.
Thanks. Thank you, Mieke. Lisa, a question that was posed quite early on when we actually started, I think it was already when Berthold was presenting, was regarding this training package. So the question was whether this package is in addition to existing training packages and whether it was linked to the WHO and the UNICEF BFHI training programs. So do you maybe have a comment on that?
Yes, thank you, Renee. So at present, the ImpENSA training program as a package is a package that's available in addition to existing trainings. But I think the idea going forward and what we are negotiating with our Department of Health, for instance, is to also explore ways how we can actually integrate the ImpENSA training package or components of that into the existing trainings of the Department of Health. The way I understand, maybe we are still in the early phases. So I think these are things that still need to be discussed and to see what would be the most effective way and how can we all benefit from this. And in terms of the second part of the comment, we did look at the WHO UNICEF 2020 updated recommendations when we developed the content. So I don't know if that answers the questions, but we did take into consideration the updated complementary feeding guidelines and the updated infant young child feeding guidelines when we revised the content.
Okay. Thank you so much. I note that there are a couple of comments regarding, well, training packages in general and the joys of people doing training and not changing practices. But I think one of the comments that I sort of want to mention, because I think it very nicely fits into with the whole purpose of what we're doing and the way in which we've packaged ImpENSA, was the comment that was made that it's very difficult to attend training seminars or training workshop during working hours. And I think you sort of alluded to that, and you also mentioned that those were some of the comments that we received during the focus group discussion. So how would you like to comment on how we took that into consideration in the actual planning of our structure? I know you've sort of alluded to that, but maybe just reiterate the individual components that can be taken separately and you sort of at your own time and pace.
Yeah, so thank you, Renee. Yes, so obviously, I mean, the nice thing about the online 2 modules that is entirely self-paced and, people can fit that in after hours, and both modules consist of 3 or 4 units, and the unit time is between, the envisaged time to complete a unit is between 45 minutes and an hour. So module 1 is estimated training time 3 hours, module 2, 2 hours, may take a little bit longer, but that can be nicely split up over a week in the evenings.
Perfect. Thank you. We've got more questions, but we have 8 seconds remaining. So it basically remains for me to say thank you so much to the presenters and to everybody. We've had a massive amount of participants. So I thank you really much for your time, and we really hope to see you as part of the ImpENSA family in South Africa going forward. Thank you very much to everybody.
Thanks.
Bye-bye.